I'd like to introduce everybody to today's speaker, Kimberly Moore. Kimberly is the Director of Healthcare Revenue Cycle Consulting at Eide Bailly and has more than 25 years of healthcare leadership experience providing services to acute and specialty hospital and health systems, both for-profit and non-for-profit, critical access hospitals, group provider practices with both single and multi-specialties, rural health clinics and FQHCs, as well as revenue cycle outsource firms. She has experience with consulting, training, business development, project management, revenue cycle leadership, patient financial services, patient access, health information management, health information technology selection and conversion, and implementation. She conducts revenue cycle improvement projects for the healthcare industry, workflow assessments, planning and execution for process improvement, and performs key performance indicator metrics management. Kimberly is a member of the Healthcare Financial Management Association, the American Academy of Professional Coders, and the Medical Group Management Association. So I will turn it over to Kim to share her last presentation. And it's *2 to unmute your line, Kim.
Sorry about that. I was talking away and forgot to do the *2. Sorry about that.
Not a problem.
This is Kimberly Moore with Eide Bailly. And as Leslie just introduced, we'll be talking a little bit about metrics today. In 1 hour to sort of build in all of the things that I love to talk about, which is how to do KPIs for performance improvement, limits me just a little bit. So I'm going to keep this part of it really short. I do want to talk just a little bit about the title of this presentation because I think it's very important that we don't lose focus. Becoming a patient-focused but metrics-driven revenue cycle team. If we think about that just for a second, the piece that matters here, there are two pieces that sort of come into play when I talk about this. One is the patient, and probably number one is the patient. And then number two being those metrics that help us to really be the best we can be as a hospital or a health system or a provider clinic. And that's to really look at those metrics and be able to take the metrics and not use them as a finger pointing, but instead use them as an improvement tool. And that keeps that patient sort of at the center of everything that we're doing. So I just like to make sure that I mention sort of why I came up with that title. Although I won't talk a lot about patients in this presentation, I want to make sure that we never lose focus on why we're trying to improve and why we're trying to, create a better process. So if after all of this is over, you guys need to get a hold of me at all, you can either go through Leslie or you could use this first slide here, and I can give you more information. We could talk a little bit about spreadsheets that I use to try to figure out my metrics when I'm working with hospitals. Okay, so revenue cycle metrics is really a puzzle. It's a way that we can take a look at each piece, whether it be customer service or it be the number of staff that we need, or it be looking at the dollars that need to come in the door based on the charges that are going out the door. If we can put them all together and measure them, it allows us to improve what we're working on. And I like this little bit of information. Comes from a book that I really like. It's a little hard to understand, but it's a book called As a Man Thinketh. And it's in all human affairs, there are efforts and there are results, and the strength of the effort is in the measurement of that result. So you can have a lot of things that we do, but if we can never measure them and show and sort of prove what we're doing, it really doesn't hold a lot of weight. So I really like that little clip, and it kind of works perfectly for this presentation that we're about to get into. I have a couple of these little things out there that you can use or not use. Discard them if they don't make sense to you. But in business, words are words. So I can talk all I want to. I can explain things until I think they're going to go away. I can make promises, but really what the bottom line is comes down to performance. And again, the way we're going to measure that performance is, or the way we're going to prove that performance is through measurement. So all of these little fun little sayings that I have, but then we'll get into the meat and potatoes of this presentation. So what gets measured gets improved. And we really have to make sure that we have all of this data available to us. And many systems out there that have tons of data stored in its walls or in that little tin box that sits underneath our desk. But if we can't get to it and really put it to play, it doesn't really mean anything to anyone. So the first thing in trying to figure out what we're going to measure is to really sit down and strategize and say, okay, what makes sense? And remember, I'm talking about the revenue cycle team here. I'm not talking about the clinical piece today, but this really does pertain to your entire facility and creating metrics that make sense to you. I have a lot of clients that ask, how do I compare, or what should my metrics be, or what is the benchmark for days in AR or point of service collection? And I do have benchmarks, and we'll talk about those today, but it really boils down to, what are you measuring against? Are you really looking at days in AR in the hundreds or 200s? Oh, I hope not. If you do, then my phone number's on that first page. But if you're measuring your days in AR as my example, and you feel like you're doing a pretty good job, then you might want to measure against hospitals that are like you. Because that helps you to then do sort of stretch goals and say, okay, if we're at a days in AR of 65 and the national average is 60, and for hospitals my size, then I could do a stretch goal of 55. That's stretching my team a little bit further than what the national average is. It's about sitting down and strategizing about what makes sense for your facility, and then comparing yourself internally to what you're doing. So what you did the last 3 months, what you did the same 3 months last year, and really comparing yourself and making sure that you're always using the same metric to gather the data. So for example, if you are comparing revenue, for example, and you're doing the last 3 months of your revenue and your payer mix, make sure that it's apples to apples, because last year the same 3 months might look a little bit different. You might have had a different payer mix. You might have had all Medicare, for example. And so your days in AR might have been lower because Medicare pays within 15 days of a clean claim getting out the door, and I can clean that up quickly. If you have high Medicaid, or you did last year, your days in AR might have gone through the roof because Medicaid doesn't like to pay promptly in some states. So you really have to make sure that no matter what we're talking about today, that you've really sat down and had a strategy and understand your data and what you're comparing yourself to. So all of that being said, providing your managers and staff with accurate and intuitive information and data. That's probably the biggest part of the recipe for making an improvement in your facility. The other ingredients would be to make sure that you are aligned in your strategic objectives so everybody understands and your C-suite gets what it is you're trying to measure, and what you're measuring relates to what your board, your finance board, for example, wants to see. If I'm measuring something out here in left field and everybody's focused on right field, I'm not going to, number one, get the credit that I deserve because I've made all of this process improvement over here in right field, and everybody's looking at left field. So we want to make sure that the metrics make sense, and then make sure that you have a process of accountability. If I'm measuring and I'm putting up my metrics in the business office and saying, okay, everybody, we collected this much cash, and our goal, we collected $1 million in cash, and our goal was $700,000. So we're doing great. That's always easy. That's the easy side of things. It's when our goal is $1 million and we've collected, $500,000. and we're not meeting what our goal is. And there has to be an accountability that's attached to making sure that we keep our metrics up to date and keep it in the positive. So we want to make sure that we're setting that accountability. And what's going to happen if we don't meet that goal? Otherwise, it doesn't make sense to set up a KPI and try to measure it. It's a lot of time that goes into pulling the data and making sure that we have the right data to not have an accountability attached to it. Doesn't make sense. And then make sure you implement policies, process, procedures that'll drive improvement. So if I'm just implementing a measurement just to measure, it doesn't make sense, and people get that feeling that it doesn't make sense. They don't understand why we're measuring. So making sure we sit down and have conversations with our team, and we're implementing for improvement. We're not implementing just for implement's sake. What happens is a lot of times, you're sitting in this webinar listening to me talk, and we're going to talk about measurements, and you might go back to your facility and go, okay, you guys, we're going to measure these things now. And if you don't understand why you're doing it, you can't articulate that to your team, it tends to fizzle, and then they lose faith in the fact that you're trying to measure things. So make sure that you've got a reason behind why we're implementing, so that there's that awareness. Stay very transparent. Either we're doing good or we're doing bad. Both need to be communicated. And if we're not doing well at meeting our metric, why are we not doing well at meeting that metric? What tools does the team need? What do we need to do? Do we need leadership support in order to make this work? Do we need community education to make this work? Possibly does the team not really even understand why we're measuring that particular item, and so they don't know how what they do affects that measurement. So really make sure you understand where you need support and where you might need to give support. And then we can really move. The industry, we keep hearing, good's not going to be good enough anymore. We're going to have to really make sure that there's that sort of value behind every process that we do. That doesn't just matter in the clinical side. That matters in your revenue cycle process as well. Customer satisfaction is going to be one of the keys to making sure that we stay viable in the future. And you all know, you're the revenue cycle people at your hospitals, you know that one of the number one things that people complain about is the billing. We don't like to mention that or say that out loud, but it's true. It's that one thing that if we did a customer service survey, I love my doctor, I love my nurse, I didn't like the noise in the hospital, or they kept waking me up to take my blood, and boy, I couldn't stand that bill that I received. Or, the person at the registration desk wasn't very nice to me. They relate to that piece of it. They understand how the clerical component of the hospital should work. They don't necessarily understand how the clinical side should work, so they don't relate to what value looks like there in a sense. They get that they got a stack of papers in the mail from the insurance company that said that we didn't bill things right, things weren't coded properly. They understand that part of it. So we need to make sure we have this clean process so we can move from good to great or great to excellent. If you already feel like you've got a good process, there are always ways we can improve. So I spent a lot of time on that slide. My apologies. It's just I like to give you that background on what it is that I really feel like you need to do to get things moving in the right direction. So when we ask those questions, how do I get to a top performing hospital? What can I do to make a difference? How can I ensure that I have quality in every process that happens within my revenue cycle? And then how can I engage my leadership? Get leadership from not just the revenue cycle team, but the entire hospital to really kind of step on board. Because revenue cycle isn't just checking a patient in or registering them or coding a claim or a chart or sending out a claim or working on denial. The revenue cycle really is everything that happens in your hospital. We can't we don't have a revenue cycle if we don't have clinical data to put into the process, right? So every piece has something to do with the revenue cycle. And so really, and you're going to hear this throughout, this kind of the theme throughout this presentation is to measure equals improvement. So what we measure, we improve. If we can't measure it, we can't improve it. So before you start any new process, make sure you can model it to measure it. And what do I mean by that? I can set up a KPI, and I could say I'm going to start tracking, financial counselors, patient satisfaction. I can say I'm going to do that. Now I have to think about how am I going to do that? Is there a report in my system that will allow me to do it? Is it a manual process that I'm going to have to go through? I come from a world of, I've been doing this for many, many years, and so I come from a world of having to create my own, tally sheet, if you will, where I would just tick off, the 1, 2, 3, 4/5, 1, 2, 3, 4/5. That was the way I kept track of how many registrations my team did. Or I'd have them stack up a bunch of paper that would allow me to go through and count, 1, 2, 3, 4, 5, 6. That's how many they did. And I'd do quality checks on them. Now we've got systems in place. And if you can use your system, work with your IT team to say, what kind of reports can I get out of here? If you don't have the ability to do that yourself. Make sure that you have the data at your fingertips, not stored in that little tin thing that's under your desk, okay, in order to improve. All right, so we kind of talked about this, but educating first. Everything starts with education. If I don't understand why I'm doing it, I'm not going to do it. That's human nature. I've got to understand what it, or at least a little bit of understanding of why it is that you want to measure. So never assume that everyone understands sort of the acronyms that you might be using. I sat in a meeting personally where I had been doing healthcare for years and years and years and years. And I always heard my finance department talk about reserves. I'd always heard them say that. And I didn't want to ask. I didn't want to raise my hand and say, what in the world are you talking about reserves? What does that even mean to me as a revenue cycle person? And back then we were called patient financial services. But as a revenue cycle person, what does reserves? I don't even get that. But I was kind of too embarrassed to raise my hand and ask the question. So that was after 10 years of being in this business and still not knowing what reserves meant. So I'm giving you my own personal embarrassment to help you understand that no matter what level your team members might be at, and if you're a CFO on the phone and you have a business office director, don't assume your business office director gets it. Business office directors don't assume your managers, supervisors get it, and so on down the road. Come at it from an educational perspective first. So define what you're talking about. And define how my job affects that performance. Me personally, I need to know why I need to do something different as a team member. Okay, and get feedback from your team. They're doing it. They're the everyday. They see what comes in from the insurance companies. They hear what the patients are saying. Don't sit in a room of leaders and sort of assume that you get what's happening on the front lines unless you two sit on the front lines. But if you sit on the front lines, you have a better understanding. If you don't, pull in a focus group. Have them give you feedback on what they're hearing. Not for judgment, but instead for improvement. And then identify the metrics that you'll use. Define that individual accountability. What does it mean to me? And then tie that to incentives or tie that to a pizza party or whatever it might be that you're going to do for your team once we meet those goals. Celebrate the positives. Don't just focus on the negatives. There will be some negatives that come into play when you're measuring, especially when you first start measuring. Realities will come into focus, and it might be realities you don't really want to see, but we need to know what's happening to be able to improve it. Okay. if you have the ability, this is a huge one, empowering self-service data data access. If you have to wait for your IT department, that's the process that's in play right now. And you might need to work through that. You might need to see if there is a way that you can get your own data, you can get your own dashboards, so that you have the ability to measure at any time during the day versus waiting until 2 weeks from now to get a report from your IT department. Pull everything together if it's possible. There are systems out there that will allow you to do this. There are some that won't. You might have to set up a manual spreadsheet to pull data together. But the more centralized you can get data in an aggregate, the easier it is for you to measure. And what I mean by that is if you have a system that does your registration that doesn't necessarily work very well with your back end, or doesn't work very well with your clinical department, or possibly you have a third-party claims scrubber, have all of that data come in together if you can, to say, okay, here's what I had in my system that was to be billed. Here's what I show in my data scrubber, in my claim scrubber, that went but had a failure. This is an example, had a failure. Here's what my credit card processing machine says that I processed versus what actually got put into the system. See if you can pull that data together. And then one extra layer on top of that for staff productivity is if your payroll system from a sense of number of hours can also come in. You could have really great data if you get that in aggregate that might provide drill down dashboards that you can actually get to the data. It allows you to identify trends and then act upon those trends, if they're positive or negative. And then this is probably a key too, is that rewarding when someone actually takes an action against data that they receive. And then share that upstream and downstream. Be a voice for this improvement process. And the way that we're able to improve is to really have real data about you, data that reflects what you're doing in your facility. And again, that's what when I first started talking, if we're comparing ourselves, we might at first compare ourselves to ourselves. And with maybe a layer of an external comparison. But at first, we need to do that internal comparison because that's going to, I might have days in AR, I keep using that just because it's an easy one to kind of talk about. I might have a days in AR of 110. Well, that's, you probably have a gut feeling that that's a little high, well, quite high. If that's your case and you're really at that point, if you try to compare yourself externally where people have 45 days in AR, that's a huge leap from 110 to 45. And that can cause some hesitation in your team. I'll never get there. I can't do that. How are we ever going to improve that much? And so they give up before they even get started. So if you compare yourself internally and say, okay, we're at 110 now, we're going to get ourselves down to 90, and here's how we're going to do it. Okay, we're at 90 now, we're going to get ourselves down to 60, and here's how we're going to do it. It allows you to take those steps, and sometimes it's baby steps and they're painful, but it allows you to show some real great movement versus 110 and we're going to get down to 45 where the industry is right now. That's a leap, and it causes people to get a little frustrated. They lose momentum. That's why we want to share realistic goals with our team and help them understand why we're doing what we're doing. But everyone can lead a change, from your person who's maybe filing papers in your business office all the way up to your CFO and your board members, and anyone can influence and be a leader of that change. And we have to make sure we empower people to feel comfortable to come in and talk with us about things that they think are working well or not working so well. So the old approach to what we used to have, that business intelligence piece, it really confirmed what was happening last month, or it confirmed what might have been happening, in the last 3 months. Today, we need to find ways to figure out what's happening today, or at, sort of yesterday, or within this week. It needs to be more real time. We need to get ourselves to the place where we can really see what we're accomplishing, understand why we're trying to accomplish it, and then explore things that maybe we didn't know, and go at those and actually make a process improvement step right now today. And we can do that through the technologies that we have now, the big data that's out there and all of the information that's available to us. And it just takes that time to filter that down through the funnel to get it to a workable, what do we need for our hospital. So the beginning, your investment in trying to set up these KPIs will be well worth it if you can set aside that time to get your KPIs set up. And they've done studies, and the HFMA has done studies, and so many other places they do studies all the time, probably more than we ever want to know. But they measure against each other. So high-performing hospitals have senior leadership that publicly supports that revenue cycle is everybody. It's not just a money thing. Denials don't just happen in the business office. They're found in the business office. It happens somewhere else. They publicly announce that kind of support. And that allows for public change. It allows everyone to feel comfortable that they can also support the revenue cycle. And so during those meetings that are revenue cycle meetings, start to invite your CFO to those meetings. He may not always be able to, or he or she may not always be able to attend, but have that invite out there so that the rest of the revenue cycle team knows that that senior leader is a part of this team too. It helps to influence change. All right. And this just kind of talks about that structure, having that key revenue cycle leader in place that is the voice of the revenue cycle team to influence some of those changes. And when you're communicating your expectations, make sure that it's clear where the opportunities are, and publicly support and praise those people that are doing what they need to do. But you can only do that through having KPIs. Okay, so now we'll get into some of that meat and potatoes behind what I think. There are so many things you can measure in revenue cycle. And I probably could have had 50 pages of just things that I think we could measure. But in reality, you probably should have 7 to 10 things that you measure. And so if I have 7 things that I'm measuring, and I have and all of those 7 things aren't quite up to par. So we have to improve on those 7 things. It's tough to do more than that. But what happens is, if I have 7 things and I've improved and I've gotten myself into the green, if you will, so I'm doing very well on 3 of those 7 measures. Now I have 4. I can add 3 more, or I can continue to process improve and get all 7 of my KPIs in the green. Okay, so this is an individual hospital decision. That's part of that strategy session. What are we going to do? What are we going to measure that makes most sense? Where is our biggest hurt right now? Is our biggest pain in the fact that we don't have cash flow? Is our biggest pain in the fact that we have days in AR that are creeping up? Or maybe it's self-pay? Or, what is causing that biggest hurt? And it can differ. And strangely, I've kind of had that both ends of the spectrum. The biggest hurt at one of the facilities I was just recently at was customer service and customer satisfaction scores. They were plummeting. that was the biggest hurt. That was a measurement that was at the top of their KPIs. We need to measure what our patients are feeling about us because, when I'm in the grocery store, I don't like to go in and have a patient come up to me and complain about whatever it was that they were complaining about. So customer satisfaction became their number one, although it was the CFO. So, the CFO, we tend to think of CFO as thinking about maybe the financial piece and the dollars and cash collections and gross revenue and days in revenue outstanding. But in this instance, it was customer satisfaction. So we need to take what we're measuring individually on what makes sense to us. So I've listed a few things on here that maybe we don't always think about, like the vendor metric. Maybe we have several vendors that are out there. And we look at what we send to the vendor, and we look at what comes back in, for early out, let's say, for example. So if we're sending all of our self-pay patients to a vendor, are we really looking at what our return is from that vendor? It's really a net back percentage. I want to know, I said $100 to the vendor. They charge me $10. $90 is what I'm expecting. If I'm only getting $50, is that okay? Is that enough money to come back in to continue using this vendor? Am I comparing that vendor to another vendor? Do I split up my alphabet so that it's two separate vendors? If you're doing, that's one area that I notice people tend to, send the information out. They never really sort of compare or do that measurement back to them to see if it's keeping that vendor. It's easier to keep them because to go through a new process would be painful. Am I looking at my payer mix? Does someone sign contracts somewhere, like a phantom signs contracts, and we in the business office never really learn about them until we get all these denials because we were billing wrong? So do I need to look at my payer mix? Has it changed? Because if I'm expecting mostly Medicare patients coming in the door, or maybe it's Medicare and Blue Cross Blue Shield, and your state happens to have a Blue Cross Blue Shield that pays very promptly, you've got it down, you've got a good biller in there at Blue Cross Blue Shield, and things are just clicking along, and suddenly your payer mix changes because a employer in the area switched coverage to Aetna. What effect does that have on you from a measurement perspective? Maybe Aetna pays in 60 days, and we can never get a claim right there. So our days in AR start creeping up. You need to know why. And if you're measuring your payer mix and you can really see what's happening, that's an indicator that will happen very quickly. You'll be able to see that come through. And so this is really about you being able to communicate with whichever direction you need to communicate with. If you are a collector or a patient account representative and you have certain things you need to measure, this will help you. If you're the business office director and you have to talk to your CFO and your team, this will help you talk both ways to help process improve and to help explain to your CFO why your days in AR are going crazy or why you have a lot of credit sitting out there. Your credit days should be less than 1 days in AR for credit. Well, maybe you've had a huge push for point-of-service collections. Only your formula is wrong in point-of-service collections, so we're way over-collecting at point-of-service, and now I've got this huge back-end credit problem. Or maybe you're looking at greater than 90 days, and your greater than 90 days looks awesome, but then we come to find out that you've got, 5 days in credit balances that are greater than 90 days, 5 gross revenue days in credit balance. That's why my 90 days looks great, because you have to make sure you're measuring appropriately to be able to enact change and to make sure you keep your AR as clean as you can or keep your revenue cycle process as clean as you can. And I'm staying on this screen just for a few minutes because we'll talk about a couple of these KPIs, and then we'll talk a little bit how to measure them in just a couple of minutes here. DNSB, discharge not final billed. So much can be within that discharge not final billed. It can be a provider that's just not filling out their charts or they're not documenting appropriately, so your coding team has to hold for queries. this is where teamwork comes into play. You have to have a great relationship with your HIM department so that you're understanding what's sitting out there in days in AR. I'm sorry, in DNFB. Because another thing to think about when we look at the DNFB is that how does your system calculate that? Is your days in AR tied to your discharge date? If it is, and you have a very large DNFB days, what's going to happen when your HIM team comes in and they just start pumping them out and everything starts hitting your AR in the business office? And everything that was in DNFB was 70 days old because we had one provider that wasn't doing what they were supposed to do, right? Or 5 providers that decided not to do their charts. That's going to hit your AR in the business office at 70 days. Now I have to be able to explain it to my CFO why it looks like my AR days are kind of going crazy because you're probably not going to be paid within, that couple of days before you hit 90 days. And now everything's going to move into your greater than 90 days. So it's about really understanding what that metric means to you and what's driving that metric. Some of it might be out of your control. Excuse me. Self-pay revenue and self-pay AR, that we're starting to see a change in that. And in some cases it looks like a positive change because we have more patients that are insured now. I call them underinsured because many of them have very high deductibles. But in my system, in my computer system, it looks like that patient has insurance. I have to take a different look and a different approach at my insurance buckets now to understand what's going to convert into self-pay. I want to know what percentage, what true percentage I'm going to get. If I have a contract with that payer and it's a 16% discount, right, off my total charges, my finance department is going to think that I'm going, I would say 15%, it makes it easier. My finance department is thinking I'm going to get that 85%. Excuse me. Sorry about that. Allergies are kicking in. And in reality, all of those dollars are actually going to deductible and copay or coinsurance. I'm not actually making money from Aetna, United Healthcare, whoever it is that's got that patient covered, although in my system it looks like that patient's covered. We have to re-look and rethink about how we're analyzing our key performance measures so we truly understand and can really start to calculate and get a true sense of what dollars should be coming back into us. So there's a lot of different KPIs on this screen, but start to identify them and understand which ones really affect your AR today and which ones you can affect change today, and then what you're going to need to start measuring in the future as we continue to move into more value-based or more self-pay dollars that look like they're insured, because they're playing a trick on your accounts receivable right now. Okay, so I'll move off this screen now and we'll kind of talk a little bit more about some of those benchmarks. There are a lot of different places out there that do try to calculate what your benchmark should be. And this very, very first one comes from a resource that we've kind of compiled through what we have at Eide Bailly, and then, I don't know, 6 or 7 different places out there that do benchmarking. To me, the benchmark of 60 days, that's too high. If I were to come into your facility, 60 days wouldn't feel good enough to me, and that's me. Again, that's where I'm saying you really have to sit down and think about your strategy and what's happening in your hospital. The 60 days is high for me when we've got timely filing. We've got timely pay laws in your state that say that claims should be paid within whatever your state is, whether it's 45 days, whether it's 60 days. 30 days. There are timely pays sort of all over the place. You need to look at your own state. Findlaw.com. Actually, you can look at your state under findlaw.com and find the law that says what your timely pay statute is in your state. So hospitals sort of nationwide are sitting at about 49 days, 40, 50 days. So if your hospital, if you're kind of in that range, maybe that's a KPI you don't actually have to be terribly concerned with, and it doesn't need to be one of your top 7 that you're going to measure. It'll be something you measure. You'll have it on your dashboards because you want to keep your finger on that pulse. But it's not one that maybe you have to improve. If you're at 45 days, you're probably looking pretty good. But then let's think about how you got to 45 days. Let's make sure that we're looking at the actual charges, the adjustments, those contractuals, and make sure that if you're doing adjustments outside of the contractual, that you have those labeled separately in your system as not just administrative, but let's label them with what kind of adjustment they actually are so that you can start to see if that insurance payer is worth keeping. And then really understanding, okay, did we just adjust off everything because the EOB came in and said that it wasn't payable? Or are we really investigating what's happening with that payer, with that denial, with that underpayment? Because I can make my gross AR days look really great by doing huge adjustments if I wanted to. And then understand your gross AR days could be affected by a single patient that's in your hospital that was in your hospital that had a very, very large dollar amount, and now it's pending for charity care or financial assistance. That could be skewing your days in AR. So make sure you understand what's in there, what's in your AR right now. You as the manager, supervisor should really understand every account that's sitting in your AR. Even if you've got thousands and thousands and thousands of accounts, you should have a grasp on what's out there. And you can do that sort of by this benchmarking. So percentage of revenue that's uncollectible, benchmark's 5. Uncollectible to me means charity care that's pending, so those things that we're writing off or that's still pending. Bad debt. And some of these metrics, when we look at uncollectibles, actually include denied claims. So the zero pay claims that we felt like they should have been paid, but they were denied. We couldn't get them to be overturned. They were the actual adjustments. So nationwide, they're falling a little bit short at 5.37 when the benchmark's 5. But see, that allows us to compare. Are your uncollectibles 10, 15%? If they are, we really need to look at how come things are being denied, how can we better affect our charity care process. Maybe we're letting too many people on charity and we're doing too much presumptive charity, and we need to sort of streamline our charity process, making sure that it stays compliant with 501R. But, these are things that we can start to look at. And bad debt. Maybe we need to do a point of service process that's maybe a little more robust. Maybe we need to implement a credit card on file process so that we stop losing money and letting it walk out the door. Discharged days from discharge to bill. So that's from when they discharges. I have a suspense time in my hospital of 5 days, let's say. So it gives my departments 5 days, which I won't even go to that, but 5 days to get everything entered into the system, charges coded, and into my final bill bucket so I can send them out the door. Benchmark is 10 days. To me, again, that's high. I have this fantasy thought that my departments should be able to enter their charges today. If they're doing the thing today, that's my fantasy. That's my utopia. And then having my coding completed within a couple of days. Anyway, it's 13.2 days nationwide. So that's falling a little short. Here's that AR days greater than 90. Benchmark 25 days or less in your greater than 90 days. and nationwide, we're actually meeting that goal. Just some other metrics that I have about 15 minutes left, so I'm just going to kind of go through these. I won't talk about every one of them because I want to get down to sort of a couple of them on how we can measure, and then give you guys a chance to ask questions if you have questions. So some things to actually measure: AR, percentage of your AR that's in self-pay. You're going to see some difference in this, I think, coming up. You're either going to see it going down because your insurance payers aren't paying timely like they should, and so we're not transferring the patient responsibilities over. So this will be balance after insurance. That is a bucket that I can't emphasize enough that you really need to watch, or maybe find a way to set up different financial classes for those that have very high deductibles. Because we're gonna need to keep our finger on that pulse too, because we're going to start to see a lot of patients come in with those higher deductible plans that they've chosen maybe on an exchange or the marketplace out there. So that's something to keep in mind. Some other metrics that you can just take a peek at and see how you measure up. If you have specific questions about these measurements, remember, this is nationwide. It's not about a hospital, even maybe your size. So you can always let me know if you have any questions as it pertains to these percentages. All right. So just some other metrics that are out there. Percentage of AR in commercial, that's probably something we're going to see change too. We're going to start to see that change a little bit. AR other, that seems like a very strange one, but that might be things that are sitting out there again, like a motor vehicle accident or work comp. So these metrics, as I said, some of them might not even compare to you. This 246 beds was an average size hospital in this. There are small hospitals that are in this survey that was done, so you guys know. This also talks about maybe the number of open accounts that you may have on your system, but again, it may not completely go apples to your facility, so keep that in mind. These are just some metrics that I believe are important for you to kind of take a look at. And I call it my BYODD. It's kind of a mouthful, but before you open daily business, I had a gentleman that sort of labeled this a little bit differently, and he called it a before 1C, which was before 1 cup of coffee. So it's the thing you look at when you first come in the morning. I don't drink coffee, so mine was before 1 Coke. I drink soda, so. But it's a dashboard that you might want to have for your team that you create that makes sense to you. I have a sample on here of what a dashboard might look like. But looking at it down to a payer level so that you can really understand what's happening with your AR. And you would do that on a daily basis, and it would look a little bit like this. This is small. If you want to see this in bigger format, let me know. It's kind of hard to put it onto a PowerPoint. But just having your key ratios, the very first thing you see when you walk in, key ratios. What is it that you want to measure? Is it unbilled to final billed as a percentage of your gross revenue? Maybe not. Maybe that doesn't make sense to you. Is it your adjustments as a percentage? You're going to have to decide what makes most sense to you. Remember those top 7 to 10 things. Maybe it's your top 5 things that you want to measure, that you want to really focus on. It truly becomes an individual hospital dashboard, and you can make it however makes most sense to you. And maybe it looks different for the managers versus maybe a account rep having her own or his own dashboard to really take a peek at. But if you can't see this, again, let me know, because I can send it to you in a different format too. So the business intelligence piece is what can help us drive those dashboards. And business intelligence might be the person sitting behind a desk that needs to spend 15 minutes entering data. But it it really helps drive much more than 15 minutes a day's worth of time. It allows us to really focus in on the areas that need improvement. So keep that in mind, that investment in the beginning will pay off for you if you can get either a manual process set up or a software that might be out there. This is a sample of a software that we at iBailey use for helping, and this can be set up in whatever format it needs to be, but so I could have this looking however I needed it to look for whatever client I'm working on. But this is an example of what a business intelligence software could do for you. If you were really interested in your payments versus your charges over a period of time, you could have this populated. It could be changed to however you want it to look, whatever metric it is that of those metrics that I have listed on the previous slides, it can look however you need it to look. Another sample of a way some people might be more visual than they are numbers driven, so you might have it more in like a graph format such as this. Some providers that I know like these little green, red, yellow. They want to see that to you know, where are they at in the DNSB, for example. If I have a list of providers that are holding my claims up for queries, if I use this kind of dashboard, it'll help to improve performance for my physicians too. There's this little competition that starts to happen, I think. Okay, so the next few slides, they're talking about what the indicator actually means and how do we get this information, and then how do we do that equation to really be able to drive that difference. So some of your front-end revenue cycle metrics, pre-registration accounts, it's the number of encounters that are pre-registered over the number of scheduled encounters. So that should be at about 98%, greater than or equal to 98% of the patients who are scheduled should have been pre-registered and financially cleared prior to coming in to have services rendered. The patient access process, total number of verified encounters. So we registered X number of encounters. How many did we go out and verify insurance on? And what's that percentage? So it allows us to say, okay, patient access team or pre-registration team or financial clearance team, here's where we are today. Let's improve on that. Let's make sure that we're at 96% in the next 3 months of every patient that's scheduled and registered, pre-registered, gets verified. So these are samples of what types of measurements that you can do in the front end that relate back to those KPIs that we've been talking about. Service authorization rates. Do we get all of our claims, all of our encounters authorized prior to them coming in? Is there a communication process with the authorization to the person who's actually performing the service so that they know what service was authorized? And if that service varies, they communicate it back to the authorization team and say, hey, we're not doing that procedure anymore. And so it's concurrent authorizations that are happening. These are conversation starters that allow you to have great communication with your team. So I won't go through every one of these, but as you can see, it kind of gives you a little bit of information and then how you can figure out what the equation is. What data am I going to need to pull? When talking about the data that you need to pull, you need to sit down and go, okay, if I'm looking at point of service collections, where am I going to get that data? If I'm posting all of my payments for a patient under a single code, how am I going to carve out those that happened at point of service or before the patient came in? I have seen facilities that also give credit to their patient access team or financial counselors for any payment that was received within 10 days of the service. And the reason for that is we know a statement hasn't gone out to that patient, so the way that the patient knew what they needed to pay was because of conversations that my financial clearance or financial counselors or registration team had prior to the patient coming in or at registration. So I give them credit for point of service, and that's part of their incentive. So how am I going to get that data? See, that's that strategy meeting I talked about in the very beginning. We need to have the strategy meeting and say, okay, where am I going to get the data? Why do I even want to measure this? What does it mean to us? And how am I going to share this data with others? Those are the things that you really need to think about when you're having that strategy meeting about what KPIs you need to use. So other ones that are involved in here, you can kind of read through them. I won't read through each one of them, but you want to make sure that you're monitoring late charges, huge effect on your process in your business office. Communicate that. I'll tell you, most clinical people that I've talked to, they really don't understand the huge process that the business office has to go through when I get a late charge in. I've already submitted the claim to Medicare. Now I have to go into the DDE system, hold that claim, let it process, get it back, send the money back, and then send the corrected claim in. Or whatever your process is in your business office. It is a big process when you get a late charge in. And from what the buzz on the street is, many payers are starting to say, you know what, I get your first claim, that's what I'm paying on. I'm not going to process late charges. That can mean the difference of a lot of dollars if you're not careful, if you've got a lot of late charge issues. So measure it. Have that conversation with your clinical team on what late charges do to you. All right. So again, a lot of different things in here. DNSP is something you might not have heard before. I've only got a couple of minutes left here. I just want to very quickly. DNSP is discharge not sent to payer. Where we used to measure DNFD, which was those things that were still sitting out there, discharge, they haven't come into our business office yet to be final billed. DNSP includes this thing called FBNE, which is final billed, not edited. In your system, it looks like the claim was submitted. It got hung up in your clearinghouse, or sorry, in your scrubber, and it still hasn't made it to the payer. I want to know all dollars that haven't made it to a payer yet so that we can process this and improve. I'm going to very quickly go through the rest of these. I know we're getting short on time here. So as you can see, I have a ton of different ratios, metrics, things like that that you can measure, down to staffing ratios. How many open accounts do you have per biller? And if you want specifics about what those numbers are for your facility, we'll probably need to talk one-on-one, because I'll want to know certain ways that you've got your business office set up or your access area set up. So let me know